Welcome to our forum on the New York Health Act, single payer in New York State. The sponsor of this forum, new NYCD 16 Indivisible, was formed as part of the nationwide Indivisible movement to take political action designed to resist and defeat the extremist Republican and Trump agendas by engaging our elected officials, particularly our members of Congress, as well as our local and state officials, and to promote progressive causes. And I think at this point we're more on the offense than the defense in a lot of areas, so we're very pleased. I'm Judy Fletcher. I'm one of the co-chairs, thank you, of the Healthcare Committee, along with Peter Weichman, if you'd stand, Peter, and Cami Seligman. And could all the Healthcare Committee members who are here, any people who made it, stand, please. These are the people who have been working, some of the people who have been working on all these issues, the healthcare issues. So yeah, we have 90 on the committee. Okay. At the December meeting of NYCD 16 Indivisible, when members were asked to prioritize their concerns, healthcare was at the top of the list. We believe that there is no more important issue affecting the well-being of all New Yorkers. This week, we saw the power of the newly elected Democratic State Senate with the passage and enactment of the Reproductive Health Act. Now we turn our attention to even more far-reaching legislation, the New York Health Act, which is single payer in New York State. This bill, guaranteeing health care coverage for all New Yorkers, has been worked on for years, and it has passed in the State Assembly for the last 4 years in a row. It is time for the Senate and for the governor to act. We are so pleased to have with us today Assemblymember Richard Gottfried, author of the bill, Senator Gustavo Rivera, the lead sponsor in the New York State Senate, as well as Katie Robbins, who's the director of the Campaign for New York Health, who has been an indefatigable advocate for this bill for many years. This forum is an opportunity to learn about the Act, ask questions, and discuss strategies for passing the New York Health Act this year. We would like to start by asking Assemblymember Gottfried and Senator Rivera to summarize the Act, what it covers, how it will be paid for, and the plan for reintroducing it. We have heard that there may be some additional amendments, and we would like to learn about those as well. And after that, we'd like to ask Katie Robbins to describe the opposition to the Act and to discuss strategies for addressing it. You can share too.
We can do a duet, Dick.
Okay. Well, good afternoon. Thank you all for coming, and thank you all for all the work that you've done in the last couple of years, I guess, that have helped to bring us to this day in the New York legislature. Long time coming. You know, millions of New Yorkers can't get the health care they need or face financial hardships and obstacles to get it. I don't know anyone who thinks that's acceptable, but there is no plan other than the New York Health Act that can meet that need. This is about real families. You know, a year ago, the Federal Reserve Board put out a study that found that 40% of U.S. households could not come up with $400 to meet an unanticipated expense if they needed to. And a couple of weeks ago, another study came out that found that 60% of U.S. households could not come up with $1,000 to meet an unanticipated expense. That relates to today's topic because the average deductible in an insurance plan in this country is $2,700. Now, and some people have deductibles much bigger than that. If you can't come up with $400 or $1,000 for an unanticipated expense, what good is it to you to have an insurance policy that may want you to come up with $2,700 before it will pay out a nickel. And that's part of the reason why in any given year, the Gallup people found that 1/3 of US households that have health insurance, someone in that household that year had to go without needed health care for financial reasons. 1/3 of households with insurance. And none of this burden is based on ability to pay. The insurance company wants to impose the same premiums and deductibles and restricted provider networks and out-of-network charges and unjustified denials of coverage, whether you're rich or poor. And if you need long-term care, like home health care, it is even worse. Before you know it, you can wipe out an entire lifetime of savings. I know that firsthand from my mother's experience. And yet we have a system that burns tens of billions of dollars a year in New York State. Tens of billions of dollars that ought to either go for health care or back into people's pockets. The New York Health Act would save from the money that we're now spending by eliminating insurance company administrative costs and profit and saving about $20 billion there, dramatically cutting the administrative expenses that healthcare providers have to incur to fight with insurance companies, saving about $16 billion, and negotiating down prices with drug companies, because today nobody has enough bargaining clout to do that. The New York Health Act would be bargaining on behalf of 20 million covered lives, and based on the experience of Medicaid in negotiating with drug companies, would save us another $18 billion for a total of $55 billion a year. Now there would be additional spending. You would be increasing healthcare spending because we would be picking up deductibles and copays and the like, and part of what that means is that people will be getting the healthcare they need instead of going without it, and that will cost about $26 billion more. And when we amend the bill to include long-term care, that will pick up a lot of the money a lot of the care that is now being delivered unpaid by family members, usually women in the family who typically give up a career and a large part of their life to take care of an elderly relative, and that would cost us about $18 billion for a total of $44 billion increase spending. When you take $44 billion away from the $55 billion that we would be saving, we're saving $11 billion. We now spend $169 billion on premiums and out-of-pocket costs and the local share of Medicaid. $169 billion, take 11 in savings away from that. We're going to need to raise $158 billion to replace that. Now, $158 billion sounds like an enormous amount of money, and it is. But it's not as enormous as the $169 billion that we would be replacing. And so the bottom line is we would be spending less money, and more of that money would either be going back into people's pockets or into providing health care. The New York Health Act would cover every New York State resident, regardless of wealth, regardless of how you got here. It would be a utterly complete benefit package covering any service that is now covered by Medicaid, Medicare, the state public employee benefit package. Thank you very much for that, by the way, because your taxes pay for it, at least for me and Gustavo. Insurance law mandates and anything that the plan in addition chooses to cover. So whether you're on Medicaid or not, whether you qualify for Medicare or not, whether you're a state public employee or not, all of those things would be covered for all 20 million New Yorkers. And when we reintroduce the bill a little later this year, we will be expanding the benefit package, as I said earlier, to include long-term care, meaning home health care primarily, and as well as nursing home care. The bill would provide complete choice of provider, no restricted provider networks, and therefore no out-of-network charges. And because of the savings that we will be achieving, we would still be doing all of this at $11 billion in savings. We would pay for it through a progressively graduated tax that would be levied on payroll income, defined as any earnings on which you pay the Medicare Part A tax. If you're employed, your employer would pay at least 80% of that. You would pay the balance. And we say at least 80% because usually through collective bargaining, some employers would be paying more than that. And the same tax progressively graduated, meaning people earning at the in the bottom bracket would be paying as a zero rate. People at the higher brackets would be paying higher rates. That same tax would also apply to unearned income like capital gains and dividends alike and the like that are currently subject to the New York State income tax, which means if you have municipal bonds and the like, those the interest on those bonds, any gain from the sale of them, is not subject to the state income tax and would not be subject to the New York Health Act. The key elements are, number one, we would stop wasting all that money and put that money either back into people's pockets or into health care. Secondly, because we would all be in the same boat, covered by the same health plan, that's the best guarantee possible for the quality of the program. Because every voter would benefit and every voter would have a stake in the quality of the program, and people in my line of work and Gustavo's will never be able to forget that. There would be a balance of pressure on the program. Today, almost all the pressure in the healthcare system is downward. It's downward on the Medicaid program because it's only for poor people. And it's hard to get a lot of support in the legislature for programs for poor people. Employment-based health coverage, the pressure is all downward because the insurance company knows that their customer is not you, it's the employer, and that the insurance company and the employer, their first, last, and always what's on their mind is returning as much money as possible to their stockholders, not to you or your doctor. Under the New York Health Act, there would be a balancing of pressures. There would be upward pressure on the program to keep it as good as possible because my family, your family, all of my campaign contributors' families, the governor's family, all of my voters will all be part of this program. There's downward pressure so that we're not, going wild because people like Gustavo and I, if we don't have to go home raising taxes, that's better. So there would be a balance of pressures which is completely absent in the current system. And finally, we would be paying for it fairly through a progressive income, through a progressive tax, not a system of premiums and deductibles where they don't care how much you make. How do we make this all happen? Year after year, the last 4 years, when we passed it with a 2-to-1 majority in the Assembly, we kept saying, people say, oh, single payer, great idea, it'll never happen. We're beginning to get to the point where it really is achievable. We now have solid majorities in both the Assembly and the Senate of people who have either co-sponsored the bill or voted for it or campaigned telling their constituents they were for it. That's in both houses. We now need folks like yourselves all across the state to make sure that the majority of the Assembly and the majority of the Senate who campaigned for the New York Health Act deliver it this session. Thank you.
So much like I did a little bit earlier today, because actually Dick and I were speaking about this and a couple of other health-related issues in the city, and then I took the car up and then he got off the train. I was like, Dick, I could have given you a ride. So much like I did earlier today, I would say ditto to what this gentleman just laid out for you. I just want to add a couple more things. First, the thing is, I always start this with the moral question. And Dick actually made a good point at the beginning of his presentation when he talked about the facts about individuals across the country, families across the country that find themselves with not enough money in their bank account to be able to deal with something, with an emergency kind of coming out of nowhere, medical emergency for insured people. We also have to talk about the fact that there are many individuals who might have enough money to deal with an emergency as a one-time basis, but let's say that sadly someone in their family then becomes stricken with dementia or has something else that requires long-term care, then all of a sudden that makes it very difficult for them financially. So bottom line is, if you have people that are making, currently the system, the way it works is you have people making decisions that are not based on healthcare, they're based on their finances. And we believe very strongly that health should not be determined by your wealth.
Yeah.
Oh, by the way, I forgot to do something right at the beginning. Thank you, by the way, because you folks actually sent me a good group of folk up to the, yes, you can applaud for that. Not only did you send me a good group of folk, but I thought, I was telling people before the election, I said, like, how do you think we're going to do? And I said, I think we're going to be in the majority, but I say, probably going to get 33, 34, if we're lucky, 35. I'm glad to know that there are people with much better imagination than me, and some of you are right here. Now I got only 39 of them, which certainly adds to the political weight of what we're going to have to, what we're trying to achieve. So back to the New York Health Act. So we start with the moral question, and then we move, recognizing that it is an incredibly complicated thing that we're trying to do. As I said a little bit earlier, our goal here is to fundamentally reshape the way that healthcare is delivered in the state of New York. And by doing that, potentially providing a model for the rest of the country. We have to get it right. Vermont, sadly, did not. California, they didn't even get it out of both legislative bodies. Right? It went out of the Senate, but it died in the Assembly. So we are doing the work that we need to do now at all levels. This is an important part of it, because the fact is that you have to have people who are willing to vote for it in the legislature, and that is a big part of where you folks came in. Now we're getting to the next level, which is making sure that the pressure continues to be there while we work on getting a version that the governor's willing to sign, and that is actually completely workable. And those are the things that we're working on right now. The biggest problem here is that we have to change people's mentality about how the healthcare system is actually organized right now. That is a difficult thing to do. When people say, as the opponents do, and I'm sure that Katie will speak a lot about this, but the opponents immediately go to the cost of it, right? How can we afford this, right? And I would quote another person that y'all sent to government, Alexandria Ocasio-Cortez, who says all the time, it's like, well, funny enough, when we're talking about wars, nobody asks how we're going to afford that, right? And I think that's a very basic thing, right? So we should ask that question: how can we afford this? Then the question I would throw back is, how can we afford to keep the system as is, considering that we already spend that much money? And Dick actually laid it out. We already spend that much money, $160-some-odd billion a year. We already spend it. Well, where is it coming from? And how is it getting spent? So it's coming from your pocket, it's going to premiums, it's going to deductibles, it's going to costs when you go to out of network, to doctors that are out of your network, you got to pay out of pocket for that. And the results that we're getting are actually not that good compared to other places in the world. So because I want to make sure that we leave enough time for questions and going back and forth. But bottom line for us is, we have to change the mentality of how people are thinking about how the system functions. The idea that your wealth should not determine your health, we need to find as many different ways as possible to repeat that. There are certainly a lot of individuals who will, when hearing that or hearing arguments of that sort, will will tell you who they are by saying that that's not my problem. That poor person or that person that didn't save enough money for that emergency, that's not my problem. They'll tell you more about who they are in that regard, right? And those individuals we can't win over. Got to identify them knuckleheads and then push them to the side. So it's either the folks who are still going to gain financially from the system, certainly Katie's going to talk about some of those knuckleheads, but then the knuckleheads who might not benefit from the system but are like fine with it and do not care what happens to other people. We identify those folks, we can push them to the side, we ain't talking to them. We got to talk to the folks that have family members, friends, neighbors who have, under the current system, even while insured, have been put in very bad financial situations, have found that decisions about healthcare are not being made by healthcare professionals, but are instead being made by people who are going to make money if they restrict care. And we got to make sure that they understand, like, the system that we're trying to have a transformation here. And it is very much not a simple thing, but it is a necessary thing. And we are closer than we've been, because this is not something new, right? We have been talking about versions like things like this, Medicare for All, and how do we actually get this to happen in our country for a while, but the voices have been kind of quieted or pushed to the side, etc. Because, I mean, one of the few, and I'll finish with this, one of the few silver linings, if you will, of the orange madness, which is what I call that thing that is currently invading us from, not from south of the border, a little bit south of us in a house that is white. There's a thing there that I refuse to call by anything else, what I call the orange madness, the orange menace. Cipollini is my personal favorite. But that administration has made all of you folks and millions of other people across the country stand up and say, we need to push back, and we need to push back in a real way. And that means that we need to get better people elected, we need to push them to do the right thing, and we need to defend ourselves and our communities from the attacks that happen from the national government. And that means, certainly as it relates to people's health care, we need to push further, and we need to push the envelope, and that we can do that together. So I will say, I believe that we're in a very good place, but the real tough part starts now. There have been many folks who are stakeholders who have not engaged in this before, because they looked at Dick Gottfried, they looked at the Assembly, and they're like, it's going to pass there, the Senate's going to be fine. It's not going to happen there. And all of a sudden, y'all helped us change the face of the Senate, and now they're like, all right, okay, let's talk now. Let's talk now. And I'm like, all right, let's talk. If you have something in good faith to bring to the table about how this could be better done, how can it be shaped better, how can it be structured better, then certainly we're willing to listen. And we're willing to tweak the bill to do those things. But if it does not deal with our basic issues, how do we provide health care for everybody? And that's not just universal coverage, which is certainly a goal, but it's also universal coverage that's the right type of coverage, not somebody else making decisions for you that are more based on the bottom line as opposed to what your health should be. So I look forward to having those conversations not only today, but going forward. And again, the tough part starts now. But we can, you folks gave us 39 people. You can give us a couple of folks like that to get some votes out of the Senate for this. Thank you so much.
Hey everybody, it's so good to be here. I see a lot of familiar faces. We've been working together to change what's politically possible for a few years now. I have the privilege of working as the director of the Campaign for New York Health, which is a statewide coalition advocating for the New York Health Act, guaranteed health care in the state. We were founded by a few groups you may be familiar with. Physicians for a National Health Program, which has been talking about this for many, many years, doing a lot of the research and evidence-based, education on why a single-payer system is the way to go. The New York State Nurses Association, which represents 43,000 registered nurses across the state. Groups like Statewide Senior Action, Commission on the Public Health System, and Metro Justice have all been putting forward this message for many years, but it's really just now resonating in a way that is so exciting because we're filling rooms like this and we've got it on the agenda in Albany. Now, this is going to be a big lift, but I'm going to talk a little bit about what we're up against in terms of getting it across the finish line and what we can do together to build the power to really win guaranteed health care. We talk about, when we go out, and we do talk about this all over the state, we are truly statewide. We have local organizing committees in North Country and Syracuse, Buffalo, Rochester, Southern Tier. This is not just New York City liberals, right? Which is what the opposition likes to paint us as, pushing this proposal. And wherever we go, we meet folks who are struggling to get health care even though they have private health insurance coverage. In fact, we have named a specific disorder, private insurance-induced stress disorder, or PIST.
Hold on. You need to repeat that because I didn't hear that before. And I'm going to use that from now on. What's it again?
Unfortunately named private insurance-induced stress disorder, or PIST. And you may have PIST. If you have ever struggled to meet the increasing premiums year to year, if your network suddenly changes and the doctor or provider you were relying on to treat your chronic condition is no longer in network, or the insurance company somehow changes the formulary for your prescription drugs and suddenly what you had been using is no longer accessible or 4 times as expensive. This is a phenomenon that is, plaguing people across the state and the country. And of course, the good news is we have a cure that is a single-payer universal healthcare system that takes the power out of the private insurance companies' hands and into a system that actually prioritizes people getting healthcare. Preventative care would be emphasized, right? The barriers that we currently face to accessing care in a timely way would be greatly reduced. I know personally, I think it's really, really important that we think about how this affects us personally, and it's not always a dramatic story that we have, right? Hopefully it's not, recognizing the devastation that can come from a cancer diagnosis for yourself or a family member. More than half of cancer patients end up declaring bankruptcy, even with private health insurance coverage at the time of sickness. But thinking about how the system is structured to actually really dictate decisions we make in our lives. When I graduated from university, I worked with both Head Start and a domestic violence shelter in rural Ohio. And countless times I was working with families who would make decisions about returning to unsafe homes because they needed to stay on the insurance of their spouse or, who is the abuser in the cases I was working with. I have a slightly happier ending to my story, but I did marry my husband 9 years ago because he was an uninsured filmmaker. He had a kidney stone. He did not go to the ER. There's that debate. What's more painful, labor or a kidney stone? And people who've had both will say a kidney stone, so shockingly. And so he self-treated at home. It was so awful. So I was like, we got to get this guy on my, not that great nonprofit insurance plan, but it's better than nothing. And so we got married at City Hall. This happens to people where you stay in marriages, you get married. What happens when you tie healthcare to employment? Well, you have people staying in jobs, right? Desperate to hang on to health insurance. You have people counting down the days until they're eligible for Medicare, to be able to make other choices with their lives. So it doesn't make any sense that we have this fragmented system tied to our income, our health status, our marital status, our immigration status. When we look at how it's done all over the world, these kind of barriers and restrictions to how you access care just don't exist. And when we think about New York State being able to lead the way in countering the opposition, we know that our neighbors in Canada did this decades ago. Saskatchewan was the first province to pass a single-payer system, and then the rest of the country followed. And let me tell you, the political legacy on the table is huge. Tommy Douglas is the father of Canadian Medicare. He was the premier of Saskatchewan when it passed, and then became the prime minister later. And he's voted every year the most beloved Canadian of all time, and he's been dead for like a while, okay? So we need to recognize the political legacy on the table here for getting universal guaranteed health care in New York State and in this country. But who do you think is not thrilled with our proposal? I heard insurance companies, pharmaceutical companies, any other?
Hospitals.
Well, yeah, very, very highly paid physicians and providers. Hospitals are not exactly out front advocating, though a little more nuanced in their opposition.
Unions.
Some unions have come out in opposition to this proposal because of the way they relate to, the healthcare insurance system through their members. The Business Council is, the group that has every year been lobbying in opposition, even when we were just passing it in the assembly, that's like, represents all the biggest corporate interests in the state. And they are incredibly influential. And so because of our campaign, I'm actually really proud to say we've inspired an opposition coalition that actually has a name. They call themselves Realities of Single Payer, and it's mostly the Business Council, New York Health Plans Association, some chambers of commerce. They are really going on, I would say, a charm offensive. This is fascinating to me, watching what the opposition is doing. They have a website now that has all sorts of misinformation about single payer, how it doesn't work, how it's too costly. But they will say they really support universal health coverage. Therefore, I've never heard the insurance companies actually talking this way, that they want, all of a sudden, now that there's this threat to their existence, they're starting to talk about, no, we really do want to cover the hardest to cover, patients in the state. So they'll say, you'll know if you're listening to someone from this opposition group, because they will say, look, we only have 5% of the population who's actually uninsured. Like, they're completely silent on the inadequacy of coverage for the millions of people who are underinsured. And they'll say that 5% fit into 3 buckets. They always use that term bucket to put people in. I'm like, can we please stop putting people in buckets? But they'll say you have folks who are eligible for Medicaid, but for whatever reason haven't signed up to be enrolled. You have a large portion of people who are uninsured because of their immigration status. If they are undocumented, you can't buy private insurance, and you're not eligible for the actual Medicaid program because of your immigration status. And then you have people who are in the income bracket where they should be buying insurance on the exchange. That's their only option, but it's so expensive that they're like, what? It's not worth it to spend all of this money for health insurance you can't use. So when you're listening to the opposition, they'll try to get you to think that the problem is just getting coverage to this 5% of uninsured New Yorkers. They will say that they have plans to do that. Their solutions are usually getting more taxpayer dollars to subsidize commercial insurance plans. So you can imagine that works really well for them. We have to reject that frame. We have to reject that narrative. Of course, we are committed to covering every single resident of New York. That is a pillar of our campaign. But we're talking about transforming the system into one that everyone can actually use, and financial barriers to care are eliminated, whether you have, no matter what. If you're a resident of New York, you get access to care. So you are going to hear more from them because they have a lot of money, and they are, definitely trying to influence this legislative session to prevent the New York Health Act from moving forward. But what we know is that the power of grassroots organizing, talking to our neighbors, getting out, telling our stories actually works. And if things go according to our plan, there will be statewide public hearings sponsored by these amazing leaders here in the legislature, so that we will have opportunities to come out. This is probably post-budget, so after April 1st, we will be able to organize people to come out and testify to our own actual lived experiences in the challenges of getting healthcare in this system. We had an amazing moment in New York City recently, just a few months ago. We finally passed a resolution in support of the New York Health Act through City Council. And we had the opportunity to hold a hearing. Over 80 people testified. I think it was more than 6 hours, 2-minute testimony, just really, really compelling. Powerful stories were told from people who want to see change in the system. Only 2 people testified against the New York Health Act. It was someone from the Hospital Association and then some brave fellow from Staten Island. So these hearings are great. It's not that we won't see opposition come out, but we need to overwhelm them with people's support for this plan. So that's going to be a real opportunity. We feel very strongly that our personal stories help to change the frame of this debate. So if you go to the website, nyhcampaign.org, we're in the last week of about a year-long campaign to gather responses to a survey, the Healthcare Rights and Access Survey, where you can share, your experience with the healthcare system. And like I said, it doesn't have to be a big dramatic event in relationship to healthcare, but have you ever felt discriminated against or challenged in affording healthcare or known anyone who has? These are the kind of testimonials that are helping us to craft a report that will come out this spring that really challenges this narrative that, we could never afford a single-payer healthcare system. Well, here are all of the New Yorkers who say they can't afford the current system. So we really hope you'll participate in that. In addition, we want all of the folks who are in office now to feel the love from their constituents. We're encouraging people to go in regularly with your testimonials to your elected officials. We have a packet we call the Healthcare Hero toolkit, where you can print out signs and drop in on your legislators to say, we really want you to fight for the New York Health Act this session. Make sure they feel the love on this. Don't let the opposition be the only voice that they're hearing from, because they're organized and that they're trying to meet with all of these folks and dissuade them from pushing single payer. And let's see, am I forgetting anything? I love the idea of the house parties, being able to come together in smaller groups, share your experiences and talk about the solution. Those are very, very powerful. We've had house parties where all we ask are, for that introductory question is, how would guaranteed health care change your life? And it's like a light bulb goes off. It's just consciousness raising about how we're actually invested in this system, and paying very close attention and support for some of the initiatives around fair elections. There's a big coalition pushing public financing for campaigns, being able to transform this session when we have so much energy, how much influence corporations have over our democratic process and who the elected officials answer to, will make it not only possible to pass and implement the New York Health Act in a way that works for people, but keep that system accountable to the people going forward. So we have a huge opportunity there. But again, the political legacy is huge. The opportunity is ours. I'm not sure that we will have a window like this in, the years that I've been working on this. So I really hope we can prioritize the New York Health Act as the way forward on healthcare. We have the opportunity to go bold, and it's going to be up to us to see it getting across the finish line. Thank you so much.
In response to what Katie just said, I do want to mention that one of the things on that table is a sign-up list if you want to be involved in house parties, because that's our next step. We have tons of questions people are just, so we'll start with this one. We have read, okay, and any of you can answer. We have read that Governor Cuomo is establishing a commission to explore how the state can provide universal health care in New York State. Can you tell us anything about this? and who would be on the commission. Do you know anything about what kind of universal health care he has in mind?
One of the great things about the budget process is that what the governor proposes is rarely what makes it to the end. There is neither Dick or myself are fans of this commission. That's an understatement. I'm sure that Dick will add some more to the fire there. But I think that establishing a commission of this is kind of gimmicky, to say the least. Which I'm sad to say is sometimes our governor kind of approaches problems that way. So I am not a fan of this, and we certainly will be telling him as much in the One House budget bills that we propose shortly. But I think that Dick probably has an opinion about this.
Well, we're in polite company, so I won't fully express my opinion about it. I've got a couple of adjectives for this commission. To answer the question specifically, who will be on it? We have no idea. It just says that there shall be a commission and it shall advise about, universal access to affordable health care. I've just now recited almost the entire paragraph to you. It says it shall report back in December, which means Lord knows when it will report. We've all got experience with legal deadlines for commissions and reports. It's clearly just an effort to try to kick the can down the road. 12 years ago, we did a commission to look at this topic. The Assembly put money in the budget. I drafted the charge to the commission in ways that I thought were a series of loaded questions that would guarantee the commission would recommend a single-payer system. The state then went ahead and appointed, as the consultant firm to do the study, I'm blanking on their name, Urban Institute, which you may not know their name, but one of their main claims to fame is that they pretty much designed the Massachusetts Health Plan, which then became the Affordable Care Act. And so that was what they were totally committed to. And so while the findings of their report made it very clear that a single-payer system would be the most efficient, effective, et cetera, way of providing universal health coverage, which is what the report was supposed to be about, they said nevertheless they were recommending something like the Massachusetts plan. This report came out in early '09, so the Affordable Care Act hadn't happened yet. So we've been down the commission road before. This is simply a gimmick on the governor's part to try to have an excuse to not do the New York Health Act. I hope both houses will consign it to the dustbin of history where it belongs.
A quick thing, I saw it. This gentleman right here works for Leader Andrea Stewart Cousins. She is not able to attend this afternoon, but he is here to report back to her everything I say, which is perfectly fine because I love my leader very much. She said she could not be here, but she wanted to make sure that her staff was here. So,
there are several questions asking the same question about vision, hearing, and dental.
Yes.
The answer is
Yes.
yes. Okay.
said another way, yup.
By the way, my own personal healthcare story, and Katie, you can take this down if you want. A few years ago, I was having my wisdom tooth pulled, and my state employee health coverage, and it's Gustavo's as well, and again, thank you for it, is basically the CSEA union plan. We're not members of the CSEA, but we have the same coverage that they do. My dentist sent me to an oral surgeon who was not in our network. He did a wonderful job. It was, you could say it was a great drug experience. he charged $1,200, which we paid. My union negotiated health plan paid $82. And, you know, I'm sure there is a dentist in Manhattan who would have pulled my tooth for $82. I would not want me or any of my constituents going to that dentist. The point is that when the New York Health Act covers hearing and vision and dental, et cetera, et cetera, et cetera, it will be on terms that are good enough for all New Yorkers and on payment methodologies that cover the cost of the care and assure an adequate supply of the care, which means it would pay a lot more than the $82 that they reimbursed me for my wisdom tooth. I take it a little personally.
Thank you. Here's another question. How can long-term funding for the system be achieved? Can there be a lockbox of revenue and permanent funding stream to assure ongoing funding? We've heard that hospitals have that concern as their main reason for opposition when they oppose.
Yeah, by law, the New York Health Act taxes would be separate from all the other taxes that the state collects. It would go into a fund that by law can only be used for the New York Health Act. And the main guarantee that the legislature would never mess with that money is that it would be providing health care not only of poor people, but of everybody, including me and my family. You know, if all of the governor's campaign contributors and my campaign contributors rode the subway, I think you can agree with me that it would be a much better ride if they were all personally invested in the quality of the subway. Likewise, they will all be invested in making sure that the New York Health Act taxes make the New York Health Act run as best a health plan can possibly be.
Would that, if, say, the Senate flipped back to the Republicans and they have an agenda to not believe in things for everyone, would it be protected from an ideological change like that?
If it's written into the law, yeah. So, yeah.
Judy?
Or said another word, yup.
Well, I want to, several people ask a challenging question, which is what happens to the jobs of people who are currently working in the insurance industry and related industries that would be impacted?
That is a very important question, and it's one that we are dealing with right now. The fact is, number one, that there will still be a need for individuals to actually process a lot of the stuff, and there will be, as opposed to being in private insurance companies, there would be in state government. So their expertise is definitely necessary. But we also want to make sure that we transition over, that we give a lot of thought to how the transition will happen. There's conversations that we are having with various unions about how to make sure that that is the case. And also consider that there will be a lot more money in people's pockets, which means there will be more money into the economy, which means that more jobs will be created. Matter of fact, various analysis have told us that a couple of 100,000 jobs will be created in a certain period of time. So there are, and I know that Dick wants to jump in here as well, but it is not something that we are ignoring, and we want to make sure that, because we know that it's one of the ways that we're going to be attacked. It's like, well, you just want to take these people's jobs away. It's like, no, we want to give health care to everybody, including them. So there's that. So.
And I'll just say, yup.
I'd like to add to that. The normal rate of reemployment for people who go on unemployment, and the Act, by the way, provided for, I hope it hasn't changed, increased and benefits for 2 years for people who are put out of work by this. And the normal rate of reemployment for people who go on unemployment is 5% a month, which means that within a year, more than half of any displaced people would already have been reemployed. Add to that the vast expansion in medical services that we're going to have as a result of it being available for everybody, we don't foresee the kind of problem that is being projected as being so dire.
Thank you, Helen Crimm. What actions by the federal government are needed to implement the act?
The answer is, and this gets asked a lot, I mean, in the healthcare world, it's called, will you get the necessary waivers to allow us to do this under the Medicaid program, the Medicare program, and the Affordable Care Act. There is provision for the federal government to waive provisions of some aspects of all of those laws for a state that wants to do something different. The answer is, it would be easier and less complicated to implement the New York Health Act if the federal government cooperates and basically says, we'll calculate with you what money we need to give you, and you put that into the New York Health Trust Fund and guarantee to us that people who would have been who are entitled to Medicare, Medicaid, et cetera, aren't going to lose anything. Easy to guarantee, and go forward. But even if the federal government, at least until January 21st of 2021, is not willing to do that, we can still implement the New York Health Act without federal government cooperation, essentially wrapping around those various federal programs. And if we didn't have modern computers, it might be pretty clunky to do that, but in a computerized world, it is possible to do that in an automated, seamless, invisible way, so that you and your doctor won't know the difference. The computer and Washington will know the difference. So the short answer is, we can do that without federal waivers. It would be nice if we had federal waivers. It could probably make it be done more simply.
Thank you. What about self-employed freelance workers who don't have an employer to cover 80% of costs? Are they a group that will have to pay much more under this act?
Well, it depends first of all, it depends on what their income is. Since we obviously have a graduated assessment, so the cost is not the same for everyone. It depends on your ability to pay. But I guess if you're self-employed, you're going to have to pick up a lot of the cost.
How does that?
Well, also, if you're self-employed, you are in the worst part of the health coverage system, because you're in the individual market, and that's the worst part of the health insurance world to be in, and you are paying the entire cost today. And again, the insurance company doesn't care whether you are a multi-million a year finance whiz who is self-employed, or whether you're a gardener who is self-employed. The insurance company wants the same premium, the same deductible, etc. And so, yeah, self-employed people will be paying 100% of the payroll tax. It will, for the vast majority of them, be a lot less than the cost of health insurance is, because that's the benefit of a progressively graduated system. And today, they're the people who are being screwed the worst.
I'm sorry, I need to respond to that. I'm self-employed, and I will pay more for socially just things. I will vote against my economic interest. But that answer is just completely inadequate. Many self-employed people, like myself, are covered by their spouse's insurance. So suddenly I have to pay insurance that I haven't paid for before. You can say that, say this is something we should do for the larger good, but you have to listen to people who are self-employed. This imposes a much heavier weight on them than it does on others. Again, I'm not saying that I wouldn't support this, because I think we need to support things that are against our economic self-interest. But you have to treat this issue more fairly than this bill does.
Well, if you're if you're covered by your spouse's family coverage, that's costing about $20,000 a year. That comes from somewhere. You might think that your employer is paying that, but any economist will tell you that it's actually coming out of your wife's paycheck. Unless you're, I don't want to get into, how much you and your wife earn, but you'd have to be earning a lot between the two of you for the payroll tax to be $20,000 a year.
So can I just jump in there? I want to say thank you for your comment, and I've definitely had periods of my life where I was a freelancer, my husband was a freelancer, and so definitely your comments resonate with me. And the idea that, we need to recognize, I think, that if we have a system that is funded fairly, the chances of any of us paying more than we do now, all of the studies do show that 90% or more of New Yorkers will pay less than they currently pay for health care. So that's where we're coming at this from, that the current status quo is a bad deal for all of us, and this is likely going to save most people money. So I'm sorry if that came off insensitively. The way the taxes are structured now too, with FICA, freelancers pay 100% rather than splitting it, right? So that is the burden, and then this would also be an assessment on income, but the chances are even, with combined with your wife's income, that we would, families would be paying much less than they do now for healthcare, and then not having any out-of-pocket barriers at the point of delivery. So I hope.
Related to that, like if you're retired, are you considered self-employed? You pay 100% of that?
Well, I think it depends on each individual's, case. Yeah. Oh, sorry. If, people who are on Medicare, for example, right now, if folks are on Medicare, you know that it's actually not cheap, right? You're paying quite a bit of money in a combination of ways, depending on how you're accessing your insurance. And so this plan increases benefits for those who are currently Medicare beneficiaries, because we're talking about covering vision, dental, hearing. Imagine your eyes and your ears and your teeth being part of your body and needing health care, so that would be part of it, and long-term care, which is the main reason people impoverish themselves to be on Medicaid. So the benefits are much better and comprehensive, actually meeting the needs of people when it comes to healthcare, and the costs are significantly lower because everything is based on your ability to pay. Chances are your retirement income is lower than when you're working. And again, that when we say 90% of folks are going to pay less, that includes everyone, no matter what their current job status or retirement status is.
Just, and a couple of more details on that. If you're retired, you're probably not earning payroll income that would be subject to the Medicare Part A tax. Your income is ordinarily at a much lower rate than when you were working, and therefore, under a progressively graduated tax system, even taxable income would be taxed at a much lower rate. And an awful lot of retiree income would be exempted from the taxes entirely because they're exempt from the state personal income tax, which is the measuring rod for whether the New York Health Act tax would apply to it. So, for example, most pension income is not taxable. Social Security income is not subject to the personal income tax. If your income is from municipal bonds, that's not subject to the New York State income tax. In addition to an awful lot of retirees' income being exempt from the tax, under the New York Health Act, we would be picking up, because we believe that people should not be paying deductibles and copays and premiums, we would be picking up the Part B premium. We'd be picking up the various deductibles and copays that the Medicare program imposes on many people, and there would be no restricted provider network if you're among the people who are now in a Medicare Advantage plan, so there would be no out-of-network charges. And so I think particularly for retirees, and let's not forget long-term care, the New York Health Act is a really important program.
Thank you. We have many questions to move on to, but thank you for your involvement. How will healthcare costs be controlled in the system? Hospitals, private practitioners, prescription meds, etc.
Well, several elements go into that. The New York Health Act would be setting payment methodologies and rates. There are criteria in the statute to make sure that those rates are adequate. The bill also allows doctors, hospitals, and the like to form bargaining units that would essentially collectively negotiate with the New York Health Act if they choose. And there would be no such thing as being told, if you want to be in our provider network, accept our bargain basement rate, because there would be no restricted provider network. You know, one of the reports that's been put out attacking the New York Health Act by something called the Empire Center, which is a spin-off of the Manhattan Institute, which in turn is funded by the Koch brothers. In a couple of parts of their analysis, quote unquote, they say that the problem is that, you know, hospitals have enormous lobbying power in Albany, and the legislature will just spend money like crazy on them. In a couple of other parts of the plan, it says our most prestigious academic medical centers are going to be paid a whole lot less and be ruined. And I keep saying to them, you know, pick a side. You know, either we're going to throw an unspeakable amount of money at the rich and powerful academic medical centers, or we're going to be robbing them blind. You know, it can't be both.
What is the time frame for action on the bill?
So there will be a reintroduction that will be happening very soon. We've been dealing with a lot of technical, but the main change is that long-term care is going to be added to it. But there's a lot of other little technical changes that they're going to be made on the reintroduced bill, I should say. Reintroduced. It's not a word. It's not a word. Not a word. I want to say for the record, not a word. Reintroduced bill. My goal is to have the entire Democratic Conference be co-sponsoring when I reintroduce it, but I'm doing the work on that now. And then there will certainly be a series of hearings that we're going to be doing post-budget. There is, as you could probably tell in the last couple of weeks, we've been moving very quickly on legislation, even from the first day. That has taken up a lot of our time, and then we have the budget that we're dealing with right now. And for many of us, it's our first budget as majority members. So it is, like literally, the reason I'm getting out of here at 2:30 is because I got to go to some meeting and then run to Albany, because I got to give a presentation to my colleagues tomorrow about how the healthcare part of the budget actually looks. And that's so we're going to be kind of really putting all of our effort into that, because we want to make sure that we get a budget passed, hopefully passed on time, certainly a responsible one. And then there will be hearings immediately after the budget. We're already kind of thinking about what some of those dates are going to be. Obviously, we'd let folks know, because we want to, as Katie said, want to make sure that we have a lot of folks there who have different parts around the state. That is a timeline that we have for right now. I couldn't tell you anything further, because a lot of this is, they're, at least in my side of the aisle, right? Or my side of the house, I should say, right? Because I'm the good side of the aisle now, but I've always been on the good side of the aisle, just to have more of them with me there. On my house, I'm still working a lot of this stuff out. I'm still talking to my colleagues, making sure that they're all in a good place, and then working along with Dick in the Assembly, who's doing his own thing over there. So as far as the timing on my side, that is how we're looking at right now. It's definitely hearings immediately after budget. We'll have dates for you folks shortly, and then we will have, and that's all I have for now as far as timeline.
Could I make a comment about that? On the table, there is a flyer that says "Take Action." And the action that we're asking folks to take is to contact their assembly member and their senator to ask them to be co-sponsors of the bill and be listed on the bill. So you'll see that Take Action flyer over there, and we encourage you to take one. The phone numbers are there on how to call the Assembly and the Senate. There's also information if you need a link to figure out who your Assembly member is or your senator is. So that's over on the table.
Great. The next question, who administers the plan? Who am I calling to resolve a problem if I have one?
Yeah, I mean, it'll be administered through the State Health Department. Some of the mechanics of it will be administered as Medicare is and always has been by one or more private contractors, but basically it'll be a state-run program. There is provision in the bill for a slice of the funding in the New York Health Act Trust Fund to be used for consumer assistance and healthcare provider assistance in dealing with the program. Because particularly at the start, people will have questions. But it will be a whole lot simpler to deal with than the current system, that's for sure.
Next question. More than 90% of companies with more than 50 employees are self-insured. These ERISA plans can be pots of gold to be borrowed against. These companies bought the Vermont plan. How do we win them over?
Well, first of all, I mean, you could also ask, how do we win over the insurance companies? Fortunately, if we win over a majority of the legislature and ultimately the governor, we don't necessarily need to win over those employers. I think an awful lot of those employers have to figure out, and it is pretty basic arithmetic, that the New York Health Act is going to cost them a lot less than they're now spending on health coverage. Unless they're among the many companies that have shifted an enormous chunk of the cost to their workers by having the workers pay more and more of the premium and higher deductibles. In which case, we ought to be able to get the support of their workers. But that's why we need a grassroots effort to get all of you and your neighbors to talk to your legislators to say you've got to make passing the New York Health Act a priority this year.
And one thing that I will add, actually, one of the things that we're doing, that the campaign is doing, is collecting testimonials, if you will, from business owners who currently offer employment insurance to their employees, figuring out how much they would save under the plan. We're also asking nonprofits to do the same thing, to just break down how much they would pay under the New York Health Act as opposed to the current reality. And we're putting all those stories together to kind of add more wood to the fire.
What if you get sick in another state?
Basically the same thing. We would pick up the costs. The state would pick up the costs.
Great. Who are the present co-sponsors in the Senate?
The bill has not been reintroduced, so it doesn't have any. But you can assume anybody who stayed with us, as opposed to the Dems who were here before, were sponsors before. So you can assume everyone who stayed from the prior Democratic conference will be a co-sponsor, and then we'll be working on the new ones.
For people currently on Medicare, will monthly costs go up? The chart looks like people earning over $100,000 a month.
A month?
A month. Earning over $1,000 monthly premium, that their $100,000 a year, their monthly premium would be $666. Is that a clear question?
Yeah, I mean, it would depend on the individual, but bear in mind that, and on the individual and where their income comes from and whether it's taxable or not. But also remember that nobody will ever have to, in New York, again, have to pay Medicare Part B premiums or co-insurance or out-of-network charges and the like. And a lot of what Medicare enrollees now have to pay for out of pocket will be covered by the New York Health Act, including a lot of dental and vision and hearing and long-term care.
Will the act provide fiscal relief to local governments?
Did we pay someone to ask that question? Yeah, the New York Health Act will shift from local property taxes to the New York Health Act tax, the roughly $8 billion that counties around the state now contribute to Medicaid. Oh, also most public employers in the state, maybe all of them, now provide employee health coverage. Instead, they would be paying New York Health Act payroll taxes, which, unless they've got some really highly paid public employees, will be significantly less than the cost of health coverage coming out of the local tax base.
Thank you. I'm a long-term practicing physician. A major problem I see, many physicians and surgeons do not accept Medicare and Medicaid. It tends to be the more elite MDs in elite hospitals. How will this be handled? In some specialties, I guess it says 50%.
I don't know about the percentages of specialties, but I would say that this is part of the argument that Dick was making earlier about the same boat argument. This will be, well, you either accept patients with the coverage or you don't see patients. Everybody's going to have the same thing. So if it's across the board and everybody's has the same coverage, then all doctors will, that'll be the one network.
My doctor, who we like a lot and we stay with him, does not accept any insurance, which means every time I go to him, I hand them my credit card and then we fight with my insurance company to get them to reimburse me. The one plan that he does accept, but which I don't use because I have my public employee health coverage, thank you very much. The one plan that he does accept is Medicare. And if you ask him why, he says, I send them a bill, they send me a check. No one else does that. So yeah, there are doctors who don't take Medicare. There's a whole lot more doctors who don't take your insurance plan, whatever it may happen to be, either because your insurance plan didn't let them in their network or because they choose not to be in your insurance plan's network. Medicare actually has the highest percentage of participating physicians of any other part of the system.
Will integrative medicine modalities be covered like acupuncture, massage, naturopathic medicine?
Every licensed profession in New York State that is licensed to deliver a service covered by the New York Health Act will be covered. So acupuncture, yes. Naturopathy, unless it's practiced by by someone who is either a physician or a nurse practitioner, not.
There's a question about preventive care. Things like nutrition education, things that should be a part of our healthcare system to help actually people stay well and be well.
I'll add on.
Well, A, it's covered, and B, today an insurance company looks at you and says, should I invest money in keeping so-and-so healthy? And the insurance company, their CFO has to say, 10 years from now, when the investment in keeping them healthy will actually pay off, chances are they'll be covered by some other health plan. So our competitor will benefit from the money we lay out to keep them healthy. Why would we do that? Under the New York Health Act, New York will know that if we invest in keeping you healthy today, 10 years ago, when it saves money, you'll be saving New York money. And so we'll have an interest in making that kind of investment.
Madam?
I just want to jump in here and say, this is one of the aspects that most excites me with a background in public health. The idea that the state would have a real interest in making sure people stay healthy, which of course is not limited to our access to health care. There are so many aspects of our lives that have huge impacts on our health and our outcomes. Our housing, our water, our access to clean food, safety in our neighborhoods. This creates a different incentive for the state to invest in all of the areas of our lives that determine our health, because it will ultimately reduce the burden on the New York Health Plan. So it's like a pretty exciting opportunity to change the incentives and the dynamics for what it means to be a resident in a state like New York.
Environmental.
Keep asking questions.
Okay.
Keep them short.
Senator Rivera has to really leave at 2:30, but we'll keep firing away. Okay.
It's like we're on the-
Will abortion be fully covered with no copay, and will that include teens?
Yes.
Yes.
Yep.
Yup.
New York City Mayor Bill de Blasio just unveiled a $100 million program to ensure low-income and undocumented New Yorkers, I think New York Cityers, have health.
Cityers? Is that a thing?
New York City
You got
residents.
young Carians and New York Cityers.
I think he who must not be named has affected our English, so maybe. So that they can have health care. This is in addition to New York City's current system of providing emergency room care to all uninsured New York City residents, costing $8 billion. Would this program replace that, and could we utilize that funding?
All the program is doing, and I like the mayor, but sometimes it gets on my nerves. He's trying to go around saying that this solves the problem. It doesn't. All that it does is money that was going to already be allocated to the to health and hospitals to actually make sure that people that are eligible and don't know that they're eligible get connected to care. So it's a great thing. Let me not, it's a great thing, but by going around and celebrating as though it solved the problem, it really doesn't. So I was a little bit miffed at them on that. But yeah, it's great. Use the money to make sure that people that don't have that don't know they currently have access to care, know that they have access to care, know where to get it, and are plugged into it.
Yeah, since Bellevue was founded in the 1700s, before I was elected, by the way, I always have to throw that in. The city public hospitals, for as long as they've existed, have offered free and sliding scale care to anybody who walks in the door who doesn't have health coverage. Part of what they're doing, which, as Gustavo said, is really good. There has been a long-term effort in the city public hospitals to shift more of their resources from inpatient care to outpatient care and to primary care, which is important and valuable. And most of the $100 million that the mayor talked about is going to be used to be hiring more primary care doctors, and they're going to give all the uninsured people who come into the Health and Hospitals Corporation a card so that when you walk in the second time, they'll know who you are and they'll have access to your electronic health records, etc. All terrific stuff. But even the mayor and Mitchell Katz, who heads the Health and Hospitals Corporation, would say, and did say, that they support the New York Health Act and that this is no replacement for the New York Health Act. In part because the New York Health Act is really primarily about the 95% of New Yorkers who have health coverage but are being screwed left and right by that coverage.
I'll do one last one in 30 seconds. What about no fault in workers' comp injuries?
We're actually talking to experts on workers' compensation to figure out exactly how to include it in the bill. But we haven't reached a final thing on that.
Thank you. I think we have to wind up. I know this is open. I'm sure these people are all willing to talk more about this if you contact them. We want to thank you so much for joining us. And we'd also like to thank all of you for coming. It means a great deal for all of us to work on this.